Your physician just mentioned a gel injection for your knee. It costs hundreds of dollars, sometimes more than $1,000 depending on where you live and what brand is used. Your insurance may or may not cover it. And you are left with the one question that nobody seems to give you a straight answer to. Does this actually work? Or are you about to pay a significant amount of money for something with no real benefit? I am going to give you that straight answer today. And it is more nuanced than either the enthusiastic promotion you may have heard from some sources or the dismissive skepticism you may have heard from others. The honest answer, grounded in what the actual clinical research shows, sits specifically in between those two extremes. And by the end of this video, you will understand exactly where your own situation falls within that range, and exactly what questions to ask your physician to find out if this treatment is likely to be worth it for you specifically. Gel injections, known medically as hyaluronic acid injections or viscosupplementation, have been used for osteoarthritis treatment for decades, and in that time, they have generated more genuinely conflicting research findings, more polarized clinical opinion, and more confusion for patients trying to make an informed decision than almost any other commonly used arthritis treatment. Today we are going to walk through exactly what these injections are, the specific mechanism by which they are supposed to work, what the actual body of research evidence shows, including why that evidence has been so famously inconsistent, and the specific patient characteristics that the research suggests predict who is most and least likely to benefit. Before we begin, subscribe to this channel right now if you want this kind of honest, evidence-based evaluation of arthritis treatments, the kind that tells you what actually works, what does not, and what falls into the genuinely uncertain middle ground, rather than simply promoting every available treatment option uncritically. Hit subscribe. Let us start with what hyaluronic acid injections actually are and the biological rationale behind them, because understanding the proposed mechanism is essential context for evaluating whether the clinical evidence actually supports that mechanism working as intended in practice. Hyaluronic acid is a naturally occurring component of healthy synovial fluid, the lubricating fluid that fills the joint space and reduces friction between the cartilage surfaces during movement, while also providing some of the shock-absorbing, viscoelastic properties that protect cartilage during joint loading. In osteoarthritis, the synovial fluid undergoes documented changes, including a reduction in both the concentration and the molecular weight of hyaluronic acid present, which theoretically reduces the fluid's lubricating and shock-absorbing capacity precisely at the point when the joint, with its already degenerating cartilage, needs that protective function most. The rationale behind hyaluronic acid injection, known as viscosupplementation, is straightforward. Directly inject concentrated hyaluronic acid into the joint space to restore the fluid's lubricating properties, theoretically reducing the mechanical friction and improving the shock absorption that the joint's own degraded synovial fluid can no longer adequately provide. This mechanism is biologically plausible and grounded in legitimate joint physiology, which is precisely why this treatment was developed and approved in the first place, and why it has remained in clinical use for decades despite the controversy we are about to discuss. The question is not whether the proposed mechanism makes biological sense, it does, but whether injecting hyaluronic acid actually produces this proposed mechanical benefit in a way that translates into meaningful, measurable improvement in the pain and function that patients actually care about. Now let us address directly why the research evidence on this question has been so notoriously inconsistent. Because understanding this inconsistency is actually more clinically useful than simply being told a single summary verdict, since it explains why your physician's opinion and your friend's experience and the latest study you read about might all genuinely differ without anyone being wrong. The first major source of inconsistency is variation in the specific hyaluronic acid product and formulation used across different studies. Hyaluronic acid injections are not a single standardized product, but rather a category encompassing multiple different brands with meaningfully different molecular weights, different concentrations, different injection schedules, ranging from a single injection to a series of 3 to 5 injections spaced over several weeks, and different manufacturing processes, including both naturally derived and chemically cross-linked formulations designed to persist longer in the joint space. A meta-analysis combining results across studies using meaningfully different products is, in a genuine sense, combining results from different treatments that happen to share a category name, which substantially complicates any attempt to generate a single, unified conclusion about whether hyaluronic acid injections work. The second major source of inconsistency is the substantial placebo response documented in osteoarthritis injection trials generally, a phenomenon that affects the interpretation of virtually every injection-based osteoarthritis treatment, including the corticosteroid injections we have discussed in previous videos. Research examining placebo response rates specifically in knee osteoarthritis injection trials has found that saline placebo injections themselves frequently produce meaningful, measurable pain reduction in trial participants, sometimes accounting for a substantial proportion of the total improvement seen in the active treatment group as well. This means that studies comparing hyaluronic acid against saline placebo injection, rather than against no injection at all, are testing whether hyaluronic acid provides additional benefit beyond what the injection procedure itself produces. A meaningfully different and more difficult question to answer than simply whether the treatment works, and one where smaller true treatment effects can be obscured by this substantial placebo response, unless studies are adequately powered to detect the difference. Before we continue to what the most rigorous, recent evidence actually shows, here is your pause. Have you had a hyaluronic acid injection before? And if so, did you notice meaningful improvement, no real change? Or were you genuinely uncertain whether any improvement you experienced was related to the injection versus simply the natural variation in your symptoms over time? Drop a comment below right now and tell us your actual experience. Real-world patient experience, understood alongside the research we are discussing, helps build a more complete picture for everyone in this community trying to make the same decision. The third major source of inconsistency is study quality and methodology, including variation in how outcomes were measured, how long patients were followed, and critically, who funded the research. Since meta-analyses examining this specific question have found that industry-funded studies of hyaluronic acid injections have historically reported more favorable outcomes than independently funded studies, a pattern that, while not unique to this particular treatment, is specifically well documented in the hyaluronic acid literature, and that responsible evaluation of this treatment's evidence base needs to account for directly. Now let us address what the most rigorous, recent evidence synthesis actually shows, accounting for the sources of inconsistency we have just detailed. The American Academy of Orthopedic Surgeons Clinical Practice Guidelines, which specifically evaluate the strength of evidence using standardized methodology designed to weight higher quality studies more heavily, and to account for the placebo response and funding bias issues we have described, have historically been notably cautious regarding hyaluronic acid injections for knee osteoarthritis, reflecting the genuine uncertainty in the highest quality available evidence once these confounding factors are appropriately accounted for. This represents a more conservative position than some other professional guidelines and reflects the specific methodological approach this organization uses, which places significant weight on placebo-controlled trial quality. Other professional society guidelines, including some international rheumatology and orthopedic organizations, have reached somewhat more favorable conclusions, generally characterizing the evidence as supporting a modest benefit for some patients, particularly noting that the magnitude of benefit, while statistically demonstrable in many meta-analyses, frequently falls below the threshold that researchers consider clinically meaningful for the average patient across a study population, even when the difference from placebo is technically statistically significant. This distinction between statistical significance and clinical significance is genuinely important and explains much of the apparent disagreement between sources that all examined largely overlapping research evidence but applied different thresholds for what magnitude of benefit constitutes a meaningful clinical recommendation. The honest synthesis of this evidence, accounting for the genuine disagreement between rigorous evidence reviews, points to a conclusion that is more nuanced than either this works well, or this is a waste of money, for the average patient with knee osteoarthritis. Across the average study population examined in this research, hyaluronic acid injections appear to provide a modest benefit beyond placebo that is real but small in magnitude, smaller than what most patients hope for when considering this treatment, and smaller than the benefit that the comprehensive conservative management program, detailed extensively throughout this channel, typically provides when implemented consistently. This average effect size, however, obscures what may be the most clinically useful finding from the more recent research specifically examining which patient characteristics predict better or worse response, a question that matters enormously more to you individually than any population average finding, since you are not the average patient but a specific individual whose particular disease characteristics may place you well above or well below that population average response. Research examining response predictors has consistently identified disease severity as one of the most important factors with patients having earlier stage Kellgren-Lawrence grade 2 or grade 3 osteoarthritis, generally showing more favorable response than patients with advanced grade 4 disease, where the joint space narrowing and structural changes are severe enough that the lubrication mechanism hyaluronic acid is designed to improve may simply have insufficient remaining cartilage and joint space to meaningfully benefit from. This makes intuitive biological sense given the mechanism we described earlier. Viscosupplementation theoretically restores lubrication function within an existing joint space, but cannot address the more fundamental structural deficit of a joint where cartilage loss has progressed to advanced bone-on-bone contact. Research has also identified that patients with lower body mass index and patients without significant joint malalignment, meaning a relatively neutral, well-aligned knee rather than significant bolid or knock-knee deformity, tend to show more favorable response, likely reflecting that these patients have less severe underlying mechanical overload contributing to their symptoms, allowing the modest lubrication improvement from hyaluronic acid to represent a proportionally larger contribution to their overall symptom picture compared to patients whose pain is driven predominantly by mechanical overload that injection-based lubrication enhancement cannot meaningfully address. Some research has also suggested that patients with lower baseline synovitis, meaning less active synovial membrane inflammation, as we have discussed extensively throughout this arthritis series, may respond differently than patients with significant active synovitis, though this specific predictor has been less consistently replicated across studies than the disease severity and body weight findings we just described, representing an area where the evidence remains more preliminary. So what does this mean practically for you, evaluating whether to pursue this treatment for your own knee osteoarthritis? If you have earlier to moderate stage disease, Kellgren-Lawrence grade 2 or 3 rather than advanced grade 4, reasonably well-aligned joint mechanics without severe malalignment, and you are seeking an additional option alongside, not instead of, the comprehensive conservative management program we have detailed throughout this channel, the research suggests you may be in the population most likely to experience the modest but genuine benefit this treatment can provide, particularly if you have not achieved adequate symptom control through conservative measures alone, and are looking for an intermediate option before considering surgical intervention. If you have advanced grade 4 disease with severe joint space narrowing, significant joint malalignment, or you are hoping this injection will provide substantial, dramatic pain relief comparable to what oral or topical anti-inflammatory medication or comprehensive lifestyle intervention provides, the evidence suggests more caution is warranted about whether this specific treatment, at its cost, is likely to meet those expectations for someone with your specific disease characteristics. The cost dimension deserves direct, practical discussion, because the modest average benefit we have described needs to be weighed specifically against the genuinely significant cost of this treatment, which varies considerably depending on insurance coverage, geographic location, and the specific product and injection schedule used, but frequently represents a substantial out-of-pocket expense even with partial insurance coverage. This cost-benefit calculation is a legitimate and important part of the decision-making process that deserves explicit consideration alongside the clinical evidence we have detailed, rather than treating the decision purely as a clinical question disconnected from its financial reality for the individual patient making this choice. The injection schedule and administration technique deserve more detailed treatment because this practical dimension of the treatment affects both the patient experience and, according to some research, the likelihood of meaningful benefit in ways that the general efficacy discussion we have covered does not fully capture. Hyaluronic acid products on the market generally fall into two administration categories: traditional formulations requiring a series of 3 to 5 weekly injections, and newer, higher molecular weight cross-linked formulations designed to be administered as a single injection providing equivalent or longer duration of effect. Research comparing these approaches has generally found comparable efficacy between single and multi-injection protocols, though the single injection formulations typically carry a higher per injection cost that may or may not be offset by the reduced total number of office visits and associated costs required, a calculation that varies based on individual insurance coverage and the specific fee structure of the treating practice. The technique of administration itself matters clinically, since accurate placement of the injection within the joint space, rather than into surrounding soft tissue, is technically more demanding for the knee than for some other joints, and research has documented that imaging guidance, typically ultrasound guidance, improves the accuracy of needle placement compared to landmark-based injection performed without imaging guidance. For patients considering this treatment, asking specifically whether the physician performing the injection uses ultrasound guidance, particularly for joints other than the knee, where accurate needle placement is technically more challenging, such as the hip or shoulder, represents a practical, specific question that can meaningfully affect the likelihood that the injected product actually reaches its intended target and therefore has the opportunity to produce whatever benefit the treatment is capable of providing. The duration of benefit, for patients who do experience meaningful improvement, also deserves specific discussion, because this affects the practical cost-benefit calculation over time in ways that a single injection's modest benefit, considered in isolation, does not fully convey. Research on responders, meaning patients who do experience clinically meaningful improvement, has generally found that benefit, when present, typically persists for a period ranging from several months up to approximately 6 months following a single treatment course, after which symptoms generally return toward their pre-treatment baseline, requiring repeat treatment if the patient wishes to maintain whatever benefit they experienced. This time-limited nature of benefit is an important practical consideration distinct from the question of whether the treatment works at all, since even genuine responders are purchasing a temporary improvement requiring ongoing repeated treatment and cost, rather than a durable, one-time solution, a distinction that matters significantly for the long-term cost-benefit calculation that extends beyond a single injection course. The comparison between hyaluronic acid injection and corticosteroid injection, which we detailed in a previous video on this channel, deserves specific clarification, because these two injection-based treatments are sometimes considered as competing alternatives by patients and physicians navigating treatment decisions, despite working through entirely different mechanisms and generally being most appropriate for somewhat different clinical situations. Corticosteroid injections work through direct anti-inflammatory action, providing typically faster onset of relief, often within days, but generally shorter duration of benefit, frequently weeks to a few months, and carry the specific risks we detailed previously regarding potential cartilage effects with repeated, frequent use. Hyaluronic acid injections work through the lubrication mechanism we have described throughout this video, with generally slower onset, often requiring several weeks to reach maximum effect, but potentially longer duration of benefit in responders, and without the specific cartilage-related concerns associated with frequent corticosteroid use. This mechanistic distinction suggests these treatments may be most rationally used for somewhat different clinical scenarios rather than as simple interchangeable alternatives. Corticosteroid injection for an acute flare requiring rapid relief, where the shorter duration of benefit is less concerning given the acute, time-limited nature of the symptom being addressed, and hyaluronic acid injection for patients with the specific characteristics we have detailed who are seeking a longer duration option as part of ongoing disease management rather than acute flare control. Though individual patient circumstances and physician judgment appropriately guide this decision on a case-by-case basis rather than this distinction representing a rigid, universal treatment algorithm. For patients who have tried hyaluronic acid injection without meaningful benefit, this experience itself provides clinically useful information, suggesting that whatever is driving their symptoms is less likely to be primarily a lubrication deficit responsive to viscosupplementation, and more likely to be driven by the mechanical, inflammatory, or structural factors that the comprehensive conservative management approach, or in more advanced cases surgical intervention, more directly addresses. A lack of response to this specific injection is not a treatment failure reflecting poorly on the patient or suggesting nothing will help. It is diagnostic information narrowing down which underlying mechanisms are most relevant to that individual's specific presentation, and therefore which subsequent treatment approaches are more likely to provide the benefit this particular injection did not. The relationship between hyaluronic acid injection and the comprehensive arthritis management program, detailed throughout this entire channel, deserves explicit clarification, because this injection, even for patients in the population most likely to benefit, should be understood as a potential addition to, never a replacement for, the foundational exercise, dietary, and supplementation interventions that address the underlying disease process more comprehensively than any injection-based lubrication enhancement can achieve alone. Patients who pursue hyaluronic acid injection while neglecting the comprehensive conservative management program, are very unlikely to achieve the best possible outcome available to them, regardless of how favorably their individual characteristics align with the predictors of good injection response we have described. The question of repeat treatment, for patients who experience benefit from an initial course and are considering whether to pursue ongoing repeated injections as a long-term management strategy, deserves specific additional guidance, because this represents a meaningfully different decision than the initial treatment decision this video has primarily focused on. Research examining outcomes with repeated hyaluronic acid injection courses over multiple years has generally found that patients who respond favorably to an initial course tend to maintain similar response patterns with subsequent courses, though the research base specifically addressing long-term, multi-year repeated treatment is less extensive than the research addressing single or initial treatment courses. For patients who have experienced clear, meaningful benefit from an initial treatment course and who understand the cost and time limited nature of that benefit, as we have detailed, continuing with repeated treatment courses on the same several month to annual schedule that provided initial benefit represents a reasonable approach grounded in their own individual demonstrated response, even in the absence of extensive long-term randomized trial data specifically addressing multi-year repeated use. This is the honest, complete answer to the question this video opened with: can gel injections really relieve joint pain caused by osteoarthritis? Yes, for some patients with specific, identifiable characteristics, modestly as part of a comprehensive treatment approach at a cost that deserves explicit consideration. No, not as a dramatic, standalone solution for everyone with knee osteoarthritis regardless of their specific disease characteristics, and not as a substitute for the comprehensive management approach that remains the foundation of effective treatment for this condition at every stage. The broader lesson this entire discussion illustrates about evaluating arthritis treatments generally, a lesson that extends well beyond hyaluronic acid injection specifically, is the genuine value of understanding not just whether a treatment works in some general, population average sense, but specifically for whom it works, through what mechanism, at what cost, for how long, and how it fits within a comprehensive treatment strategy rather than functioning as an isolated, standalone intervention evaluated purely on its own merits, disconnected from everything else a patient may be doing to manage their condition. This nuanced, mechanism-based, patient characteristic-specific approach to evaluating treatment evidence is considerably more useful, though admittedly more complex, than the simple does it work framing that so much health content defaults to. And it is the standard of evaluation this channel will continue applying to every treatment option we cover. You now have the complete, honest picture of hyaluronic acid injection for knee osteoarthritis, the mechanism, the genuinely complex and sometimes contradictory evidence base, and why that complexity exists, the specific patient characteristics that predict better and worse response, the practical considerations of cost, administration technique, and duration of benefit, and the appropriate framing of this treatment as one tool within a comprehensive management approach rather than a standalone solution. Use this complete picture, combined with a direct conversation with your physician about where your own specific disease characteristics fall within what we have described, to make the informed decision that this treatment, like every treatment decision in managing a chronic condition, genuinely deserves. If this video gave you the honest, nuanced answer about hyaluronic acid injections that you have been searching for, rather than either uncritical promotion or dismissive skepticism, please support this channel. Hit the like button right now. Subscribe if you have not already, because we are committed to giving you exactly this kind of complete, evidence-based evaluation for every treatment option this channel covers. Share this video with someone who has been told to consider gel injections and deserves this complete picture before deciding. And leave a comment below. Tell us where your own disease characteristics fall within what we have described, and whether this changes how you are thinking about this treatment option. We read every comment. Thank you so much for watching. See you in the next one.